Welcome back. Dr. Tom Meade with part 2 of a special edition of Living with COVID-19 in Orthopedics. And my guest is Dr. Eric Lebby, Chief of Orthopedic Surgery at Lehigh Valley Hospital. I hope you enjoyed the first show. We have so much information, we decided to roll right into a second show and hopefully continue with some valuable information. We left off talking about the value of virtual visits. And one of the things that I really learned is that post-operatively, patients come a large geographic area, and many of them don't need to come in the office. They come a long way, they drive, they park their car, they come in, they check in, they sit in the waiting room, they come in, and I know Eric is always on time. He's never behind, but occasionally he could be 2 to 3 minutes behind.
Right.
And then we look at their incision, and we go, great, and then they have to drive an hour or two home. So in my world, that was one of the biggest advantages. Dr. Lebby has some other examples, and I could think of some too, but certainly you were talking about other opinions or...
Yeah, sure. Well, first of all, thank you for having me back to another show. I really appreciate that. And my point is that a lot of times, especially in the past, we could be 6 weeks, 8 weeks, 10 weeks booked before the patient actually comes in. What I look at in the future for video visits is now I can make that visual connection with the patient. You know, hi Jim, I'm Dr. Lebby. I look forward to seeing you in 6 weeks. You know, let's listen to your story. Let's hear what you're dealing with. And I want you to know that in 6 weeks, when you see me, we're gonna fix this. We're gonna make this better. So now the patient and I have made a connection, right? And they can hold on to that for a couple weeks and not be sitting at home saying, well, when am I gonna meet this guy? Who is this guy? Well, what's he gonna do for me? You know, so I've kind of, we've met each other, we've made the connection now, and the patient's from far away, and now they have something to look forward to, knowing who they're actually coming to see. So that's kind of another area in video visits that I see. I totally agree with you with the surgery patients. You know, it's a great thing to look at a wound if they have an issue, if they have a question or problem. We're just a phone call and a video away.
I agree.
You know?
Yeah, any complication. You know, we get the call, my knee's a little red, it's a little swollen. The first thing you think of, this could be catastrophe, it's infection. They say, I have a little drainage. Oh my God, the red lights go on. But boy, you just say, oh, well, you know, let's do a video visit and look at it. You say, oh, it's absolutely normal. That's a fracture blister. It's not anything important. But you know what I notice, Eric, is one of the value of being in practice for decades, 20 or 30 years, the amount of knowledge that we have in our head from listening to patients. And if you just take the time to listen to patients in orthopedics, probably 90 to 95% of the time, we have the answer.
And the patient does. They're telling you.
And the patient does.
Right.
If you're just patient and you don't rush them through. And so you say, I go into an exam room and 95% of the time before I touch them and examine them, I know what's wrong. And this is the value that we have after being in practice. Now, I said it's a little harder for the resident who's out in his first year and he's doing a video visit. And let's say the patient comes in and goes, my knee is killing me. And as soon as I see this, his knee is killing him down his calf. And he says, and it hurts me at night, and this knee hurts me all the way up to here. You don't even have to examine him to know.
Yeah, it's likely his back.
It's likely his back. He has nerve pain. And he's going, my back. He's going, my back is, how did you know that? It's a video visit. And you go, well, I have 30 years.
You have the knowledge.
You have the knowledge.
Yeah.
And so that is the value, you know, of us doing that. And so anyway, I think going forward, it's going to be more convenient for us because it's going to be more convenient for the patients in selected patients. So I think
absolutely.
That's one of the values. Now, so now we're ramping up. All of a sudden, things change daily. In this pandemic, all of a sudden, the governor came back, and it was a surprise to me. I don't know if it was a surprise to you, but Tuesday, 2 weeks ago, elective surgery is open.
Yeah, that was a surprise.
It was a surprise.
That was a surprise. All of a sudden, everything just...
And did you think this
switch got flipped?
Did you think this was funny? That two things were now available: elective surgery and golf. And
Yeah.
did you think he was thinking about doctors that like to golf?
Well, I am a golfer, and I was very pleased to hear that. But again, I think it's a smart thing, because what's golf? You're outdoors, right? A lot of people are walking. 18 holes of golf, if you're walking, is about a 5.5 mile trek.
Yeah.
And it's not all level ground, so it's exercise, right?
Yeah.
You're outside. It's like you said earlier. I believe it was the last show you mentioned, the stay-at-home order. Just because you're staying at home doesn't mean you're safe, right? They're not synonymous. You can be at home and not be safe.
Yes.
And not thinking about things like exercise, sleep, nutrition. Those three things, along with the so-called mitigation that we hear that term so much, mitigation.
Yes.
It's like that's the new buzzword. We have to mitigate.
Yes.
What exactly is mitigate? Is it migrate? Is it mitigate?
Yes.
What's that mean?
Yes.
Well, it means we have to stop this.
Yes.
And the way to stop it isn't only the 6 feet apart. It isn't only the wash your hands, which is all very important. But you have to do things to improve your own personal immunity in order to be really safe during this time and other times.
I just have to insert a bit of humor here, but you brought up mitigating in terms, and do you ever notice that there's certain words that sort of like have a time span? Like
They have a birth.
They have a birth.
They have birth and a death.
They have a birth.
Yeah.
And so, do you remember when segue was the big word?
Oh,
We're
yeah.
going to segue.
We're going to segue into
Now
here.
we're going to pivot.
Yeah.
Do you notice we're pivoting now? We're pivoting. I used to pivot.
mitigating.
To mitigating. And we're not passing information on to our colleagues, we're cascading it.
Yes.
We're cascading. So there's no words, and I just think it's kind of
yeah.
funny.
Rolling Stone gathers no moss.
So back to point. Pennsylvania is one state, but it is not one geographic area. It is not one area with the same demographics.
Such a
And
good
a
point.
lot of our colleagues, we have a lot of colleagues on the on the western part of the state. Pennsylvania is a plethora of great medical institutions. We have, I don't know the real statistic, but we have more medical schools and hospitals than many other states. We have maybe 8 in Philadelphia, 1 in Pittsburgh.
I think the fact that amazes me is 1 in 5 orthopedic surgeons have some connection to Philadelphia.
Yeah.
It's amazing.
It is amazing.
That's in the whole entire country.
Isn't that wild? Yeah, it's
1 in 5.
I mean, to train in Philadelphia is a privilege and an honor, and both of us have trained there. And there's a lot of, I call it orthopedic incest in Philadelphia, because I trained at Jefferson, which sort of had some attendings that were from Penn. Actually, our chairman, which was Dick Rothman, came from Penn before he was our chairman. And then there was a time where they still operated at both, and I think Dick Rothman and Bob Booth were really some of the icons of orthopedic surgery.
There's a lot of history in Philadelphia.
Yes.
The grandfather of orthopedics, John Lockman, was a Temple guy.
Yes.
Dr. Royal Moore.
Yeah.
He was.
Oh.
I mean, it's
The
list of amazing
Man,
physicians that came from Philadelphia.
And these are, I mean, Dick Rothman, unfortunately just passed this past year, but he was working right up until the end.
Yeah.
Anthony DePalma, which was his mentor.
Mm-hmm.
And on the show, I've mentioned it before. Who would have thought that Anthony DePalma did a surgical internship in Coaldale, Pennsylvania in 1920? I mean, he spent a year up here, and that's because, and I've always said this on the show, he was Italian, and he was prejudiced against in Philadelphia. But yeah,
but I think you bring up a great point about Pennsylvania. Is I think more than any other state in the union, you can find almost every single type of person and almost every single type of geography in Pennsylvania. You look at, it's really east and west of the Allegheny. They're almost 2 states within a state.
Oh, for sure.
Right? And there are so many different pockets in our state with so many different people from so many walks of life. And I think that's what makes our state of Pennsylvania one of the richest states in the union, I think.
Oh, and keep that point. I'm going to talk about diversity of the East and the West in 1 minute when we come back. Stay with us. Folks, I'm back with Dr. Eric Lebby, Chief of Orthopedic Surgery at Lehigh Valley Hospital. We're just talking about the diversity of orthopedics in Pennsylvania, and the abrupt opening of elective surgery took us both by surprise. But whether it's related or not, and thank God we're in medicine and not politics, but the week before that, some of my colleagues out at UPMC decided that they are not like New York or New Jersey, and they followed their numbers very closely. And they said, I believe, they only had 130 cases that were discharged from the hospital. And they said, we've learned an awful lot. We think we're safe. We're using social distancing. The whole world has changed, but we think it's safe to go back to doing orthopedic surgery. And you know what? Healthcare is one of the biggest employers in the state. And
I think UPMC is the largest employer in the state,
really?
I believe, yes.
So, you know, after this pandemic, we need these institutions to help us when we have trauma, when we need a liver transplant, when we need services. So I don't think that there was a lot of reasons why they couldn't do that. And then a week after that, I think a lot of other hospitals said, we're in the same position.
And it's working.
And it's working.
It's working.
It's working. And we were in a better position, I think, at Lehigh Valley.
Yeah.
We were, at least in our area, we had the advantage of having 3 COVID-free hospitals. What does that mean? It meant that we locked down at the beginning, and there was not one COVID-19 patient in those hospitals.
No.
And
not at all. And it's our Tillman site and the 2 coordinated sites.
Yes.
The coordinated Allentown, coordinated Bethlehem.
Oh.
And what's really nice about these hospitals, Tom, is that not just the patients, but it's the doctors. And actually, Tom, it's any employee in the hospital that has any patient contact. So the cafeteria team, the cleaning team, the nursing team, the pharmacy team, we all get tested every week. And I've already had 2 tests. You've already had 2 tests, right?
Did you enjoy it?
No, it's not fun.
It is not
No, it's not fun. It's not fun. I swear they took a lung biopsy one time through my nose.
I thought it was a biopsy of my cribriform
Oh my God.
plate.
Oh my God. That was not fun. But everybody that's tested wears a green band. And I'm working on getting the surgeons to have a lanyard that's green because we can't wear bracelets because we have to operate. But all the nurses on the floor, all the people that have had tests have the bracelet, and the patients are tested. So no one in the hospital has COVID. And you can feel safe as a patient to know that you're in an institution that has never had COVID present. Our hospitals were all closed during, from that date you said was March 19th.
Yeah.
They were shut down from March 19th until last Friday, or 2 Fridays ago now. I think this is our 2nd full week of surgery, and it's been very successful. And to be honest with you, Tom, I feel no different now than I felt before the COVID crisis on how our hospitals are running. In other words, they're running very well. And the patients that I've brought in and discharged already have already said to me, I feel very safe. And that's key, because our goal is to make you feel safe. If we can't make you feel safe, then we're not doing our jobs. And I think at these 3 hospitals, you won't find 3 hospitals that are better at keeping you safe when it comes to the COVID issue.
I agree, and patients have that trust. When we schedule their surgery now, and we tell them that this is a COVID-free hospital, they said, "Oh my God, thank you. I don't, why would we go into a hotspot hospital to have elective surgery? I'm not sick. I've tested normal." And as we're discussing this, up on the screen, just an FYI, are these test sites where patients could go. These are not the test sites that if you think you have COVID because you have
symptoms, separate sites, right?
If you have a fever or sore throat, these are separate, isolated sites where elective patients can go and feel safe, and they are being tested in in preparation for their surgery.
Exactly. And Tom, I think something else that the viewers need to understand is the three hospitals that we're talking about now are Tillman, or we call it the Center of Orthopedic Medicine at Lehigh, and Coordinated Health, Allentown, Coordinated Health, Bethlehem. Guess what? They were very, very successful before the COVID crisis, right? Very low infection rates, very low complication rates at all three of those institutions. And we do a lot of elective orthopedic surgery at those sites, right? So it's not hard for our sites to come out ahead in this because we were so good before. And that's a big key. You can't just hang up a shingle and say, we're good and we're COVID free, here we are, come see us. I think that the reason why a lot of patients are coming to our sites is because they felt the confidence in us before this crisis. So they'll obviously feel the same trust and belief in us during and after this crisis.
So when we opened up elective surgery, it was not like 0 to 60 in one day.
No.
And so up on the screen are some a list of comorbidities that put people at risk. So I think when we opened up, we had some criteria.
We did.
So, and they were specifically
it was age.
It was age. So we weren't allowed to do anybody over 65.
Correct.
And then in orthopedics, we're aware of this. We have risk stratified people for a long time. We realized that if you had a certain BMI of over 40, if you had a hemoglobin A1C of over 7 or 8, if you had some other criteria, you were at risk for infection. So all we did was optimize those patients. So we didn't cancel them, but we said, we have to optimize this. We have to get your weight down to a safe level. We have to get your blood sugar under control. We have to get your hemoglobin A1. Well, it's the same thing now that they're doing with COVID. They've sort of risk stratified.
Correct.
So, but we have some issues with that. I think just like in orthopedics, I think if you pick all 65-year-old people and a BMI of under 35, you are missing a lot of healthy people that are older.
There are a lot of my patients that are 70 plus.
Yeah.
That I would put up against my 50-year-olds, without a doubt. I'm talking about ex-marathon runners, I'm talking about tennis players, golfers, people that ride hundreds of miles on their bike a week. And there's a reason why you make it to 70 and 80, right? You've led a healthy life. So I find a lot of my octogenarians, even my 80-year-old plus, I put them up against much younger patients. But remember, the issue is, as we age, no matter how healthy we are, I like to use the analogy of a car. You can have a beautiful car that's 30 years old.
Yes.
Even at its best, it's not going to run like a new car. The systems kind of are a little less efficient, and you have to keep that in mind. But I think as surgeons, we understand this, and thankfully, the hospital has let us give our input and realizes that there are certain 70-year-olds that are healthy. There are certain 75-year-olds that are healthy, certain 80-year-olds that are healthy and can have elective surgery. And it's what you said, Tom, it's all about stratifying risk. If you're an 85-year-old and you have chronic lung disease, you have heart disease, you have uncontrolled diabetes with an A1C above 8, you're not going to be one of those patients that we can operate on electively now. But as long as we can maximize your health and stratify the risk, we can get it done safely.
So great, you just stimulated my thought before. I want to come back with my car analogy and tell me if I'm crazy. I want to look at some real numbers, and we'll touch base on the way out on some nutraceuticals that can boost your immune system. So stick with us. Hi folks, and welcome back. I'm with Dr. Eric Lebby, Chief of Orthopedic Surgery at Lehigh Valley Hospital. We are discussing living with COVID-19, the new orthopedic world. Where we left off, I asked Dr. Lebby if he thinks I'm crazy to use this car analogy. But there's risk to everything, Eric. There's risk to everything. And I look at comparing the COVID-19 risk in some ways to driving a car. Every time we go out, 55,000 people a year die of a car accident, okay? So we're assuming that risk. if we don't want anybody to die of a car accident, then we shouldn't. Then we don't drive. Everybody would say that's unacceptable, and also everybody thinks they're not going to die of a car accident.
Correct.
Okay, so I think that the best way to mitigate, because I'm going to use your new word. I'm going to use your new word. I'm going to pivot.
Love it.
I'm going to pivot into this.
I'm going to pivot into it. We'll cascade the answer.
So I think the best way to avoid dying in a car accident is to load the deck in your favor. And what does that mean? It means go out and put your seatbelt on, drive under the speed limit, listen to the traffic laws, stop at all stoplights. Be as careful as you can. And you know what? If you do that, I think that you will have a much lower risk of dying in a car accident. Now, if you go out and drive 90 miles an hour, you drink and drive, you swerve across the midline, well, you're going to have a much higher risk of dying. And also, I will have a higher risk of driving if there's more of those people on the road. So now, I can't stop those people from driving, just like I can't stop people from congregating in big groups, not wearing masks, coming up to me, and it's sort of the same risk profile. So I think that if you want to avoid dying in a car accident, and let's say your driving skills are slower because you're older and you live next to I-95 and you're afraid to get on that, well, you know what? Most people, when they get to be 95, they will stop driving because the risk is there. Well, I think the same thing is true with COVID. I think that if you are at risk with some of these risk factors that are on the screen, if you are older but not healthy, you have chronic lung disease, heart disease, you're immunosuppressed, morbid obesity, kidney disease, well, maybe you shouldn't drive on I-95. Maybe you should stay home and not drive. And maybe if you are younger, have no comorbidities, and you wear a mask and you social distance and you're healthy and you sleep and you exercise, perhaps then you could drive in the correct lane with your seatbelt on. Is that a crazy analogy?
No, and you know what? I want to take your analogy and take it a little step further, because I use this analogy a lot when I'm talking to people. Is it's not just what you're saying about the car, driving the car at a certain speed, wearing a seatbelt. It's also about how you take care of the car, right? So if you abandon your car, you don't take it to its checkups, you don't fill it with the right gasoline or make sure the oil is checked, your car is not going to function well. Unfortunately, that's a lot of what we do to our bodies. People tend to take better care of their cars than they do their own bodies, right? So, you make sure your car is inspected, you make sure it has the oil changed, the spark plugs, all the car stuff that you need to check. But when it comes to stuff like nutraceuticals that you and I are very involved in, people don't check which one they're taking. They don't realize, they don't care. We put things in our bodies that none of us would put in our cars, right? So if you're not taking care of your car, you can take that analogy and say, well, how do I take care of myself?
Yes.
You mentioned sleep, you mentioned exercise, you mentioned nutrition. And no matter how much we eat, no matter what we consume from our diets, a lot of us aren't getting enough of the nutrients that we need. Take vitamin D, for example, right? I think it's a great vitamin to bring up now, because how do we get our vitamin D?
Yeah, sunlight.
Sunlight. Where have we been for the past 2 months?
Inside.
Inside. Are we getting sunlight inside?
No.
People are huddled in their homes, right? So we already have a problem in this country with vitamin D deficiency. So we should start thinking about fortifying with vitamin D. I think one thing that you and I can both admit to everyone out there is, when we were in medical school, nobody taught us about nutraceuticals.
No.
Nobody taught us about nutrition.
I had 1 hour.
An hour, right? So the thing I like about you so much is we're very similar in that way, is we did the research on nutraceuticals. And that's a big part of both of our practices, is really teaching our patients how to do that properly, what nutraceuticals to take, how to take them, and the quality of the nutraceuticals to take.
Oh, exactly. And what's interesting in this COVID crisis is brought it up even more. And although a lot of my patients, I've been looking at nutraceuticals that are natural anti-inflammatories, in lieu of or in addition to non-steroidals, which we talked about had a high risk. But almost all of the ones that you mentioned, vitamin D, vitamin C, they're antioxidants, they're anti-inflammatory, but they also boost the immune system, along with fish oil, CoQ10, vitamin C, and zinc. I mean, these are things, if you're deficient in them, you're going to be at risk to catch a cold. What's a cold? A cold is a COVID virus. This is only the 7th COVID virus that they found. And, we're looking for a vaccine for it, and that's great. But you know what? To date, why don't we have a vaccine for the cold? There has been no vaccine for the common cold. So hopefully this will change. But you know what? We can't wait for a vaccine. We can't wait for medication. We're going to live with COVID-19.
And that's why we need to optimize our immune systems.
We have to optimize it. Absolutely.
And for you and I who do surgery, people with a strong immune system heal well. People with low zinc levels, people with low levels of vitamin C, low levels of vitamin D, their wounds don't heal as well. And their post-operative process is much more tenuous.
Yeah, no, I think that we were on the right track a while ago, but I think this whole crisis has brought up the need to bolster your immune system and your nutrition pre-operatively and post-operatively.
Optimizing your health.
I think we've looked at fish oil, we've looked at L-arginine. They both help with wound healing, decrease infection, and I think we could talk for another hour, and we may do that. We should have another. I want to leave you with a couple thoughts. This is a slide. This is my thought of the forecasters that we're trying to make sense of. It looks like the European and the American hurricane forecasters, and I just want to leave you with a couple thoughts. Is that we've had Athlete of the Year award, and that's on a slide. That is not going away. It will be virtual, so that's going to be on PBS on May 19th. So I want you to stick with us. And anybody that has an orthopedic injury, we talked about virtual injuries. Now have a virtual injury center. There's the information on the screen. I want to thank Dr. Lebby for being with me today, and hopefully he'll join me on another show.
I look forward to it, Tom. Thank you very much.